I can just say that, even part of this work, right? I love it and I enjoy it, but I can feel that sometimes if I'm not feeling very well, I'll turn to more busy work just to fill my time so I don't have to think about things. And that's a form of escapism that has a potential risk for addiction. And so I'm not denying the ordinariness of this, that everyone has this. And it's not something we completely extract from our day-to-day lives, but it's something that we want to be aware of and have a way to cope with.
Absolutely true. And I sometimes think that the sense of non-normality that comes along with addiction is someone's own defense against it. Like, that could never happen to me. That is so abnormal. Oh, that only happens to people who are XYZ, right? As opposed to, this could happen to anyone for anything. And it's not just substances. There's video game addiction. There's caffeine addiction. There's the idea of procrastination through productivity is something that I've certainly fallen into myself. I'll organize email up, down, left, right, and center instead of just answering it. Yep. I certainly understand that. And so sometimes finding that core of we're all human, we're all going through it, and there's a way out of this that is not motivated by shame. That shame is not an effective motivator for recovery.
Welcome to the Good.Enough.Shrink podcast. We are your hosts. I am Jenna Chang, a child, adolescent, and adult psychiatrist practicing here in Los Angeles, California.
And I'm Dr. Patrick Kelly. I am also a child, adolescent, and adult psychiatrist practicing in the Los Angeles area.
We are on a mission to demystify child psychiatry and have conversations surrounding difficult topics on youth and adult mental health, but not without a little play along the way. So, welcome back to the podcast. Today, we're talking about addiction, and I actually wanted to start out with a story. So, as an intern is your first year of residency. We used to have this thing called house call, where we basically man medicine calls throughout the hospital. And one of the tasks we had was to man the detox unit. Our hospital had a detox unit. And there was one patient, and I will change some of the identifying information to protect his identity. But essentially, this man was in his late 40s. He was a fairly high functioning person. He had a corporate job, came from very humble beginnings, pretty horrific abuse and neglect history, but worked his way up the corporate ladder, got married, had a son, was really trying to build his life. Unfortunately, very early in his life, like he was 16, he started using weed, alcohol, and then spiraled into heroin. That was his main drug of use. And he would have these bender episodes every few months. So I saw the name and I recognized him and I just thought, okay, he's back. This is like my third time seeing him that year. And I went into the room and I'm doing my physical exam. And in the middle, he gets a phone call. He said, "I'm so sorry. Can I just take this? I just really need to take this." And I said, "Oh, that's fine." So I went to the computer and was working on something, but obviously I'm in the room so I can hear the phone call. And it's his wife. And he's like, "Oh, honey, I'm so sorry I missed your call earlier. I've just been in so many meetings. Oh, the flight was fine. The hotel's, the hotel is what it is, does the job." He is telling his wife that he's on this work trip and he's going to be gone for 5 days. But his wife had no idea that he was on this detox unit on a pretty intensive detox regimen of Librium taper, and our attending also used phenobarbital for 5 or 6 days. He was an IV heroin user as well. And so he had an abscess on his arm that we had to drain. And his wife has no idea. She thinks that he's on this work trip that he takes every 3 to 4 months because he's high up in corporate. And he hangs up the phone and he looks at me and he goes, "My wife will never know. She can never know about this."
Wow.
Yeah,
And
I
was
just
that the end of the discussion?
yeah.
And we're moving on from that? Wow.
Yeah. Then we finished the exam. He said thank you and quite polite. He just knew that he could never disclose that. And you could see it too. He was so full of shame that he didn't want to talk any more about it.
Right.
So I didn't press too much, but the walls were up very high. And this cycle of going on a bender and then detox and then coming back home, all polished and okay again. It just was never ending. And I think that's part of the issue is that it's so hard to face the honest truth. In these situations, you don't realize that's the actual perpetuating problem is that you're lying to yourself.
Shame is the killer.
Yeah.
So there are different ways to treat substance use, and one of them is the idea of a 12-step program, Alcoholics Anonymous and similar things. And baked into that philosophy from somewhere in the early 1900s. Even they say that dishonesty is the number one killer. It's what prevents recovery. Dishonesty towards others, dishonesty towards yourself, that a radical honesty, which now we call radical acceptance. In psychotherapy, we've sort of taken that idea and really run with it. But the idea that if you can't be honest about it, it's so hard to change. You're just an island with no one around to help you.
Yeah. Despite this current picture of addiction, which is extremely negative and there's a huge stigma about it as well, the term itself, addiction, originated from the Latin root word, I'm going to butcher this. No,
Adicere.
adicere. That sounds right. Meaning assigned to, with both positive connotations of devotion and dedication and negative connotations of being enslaved or indebted. So for years, it was just something that people were simply passionate about, like a habitual activity of interest. But then in the early 1900s is when the pathological sense of the word arose. So creditors would use this to signify that this person owes them debt. Pulling back to the current times, the American Society of Addiction Medicine defined the term addiction in 2019, and they were really careful about it in the language. They said they wanted to make sure that the stigma was addressed and that there was a hopefulness in the definition itself. So they defined addiction as a treatable chronic medical disease involving complex interactions among brain circuits, genetics, the environment, and the individual's life experiences. People with addiction use substances or engage in behaviors that become compulsive and often continue despite harmful consequences. And of note, prevention efforts and treatment approaches for addiction are generally as successful as those for other chronic diseases. So, really, a hopeful message, and also facing the facts, which are the harmfulness and the compulsions.
Yeah, and I think I trained at a slightly different time where there were different philosophies on addiction. And it is a fine line. There are some well-meaning people who do try to use stigma almost as a change element. If you feel bad about this, maybe you'll stop it. Then we still see it, but I think there was a lot of judgment and stigma against addiction almost as a barrier to entry. You would never want to be one of those people. You would never want to pick up a cigarette because then you turn into a chain smoker, the gateway drug. You never want to start using marijuana because that's just a pathway to heroin. And I think the most positive spin you can put on that perspective is that it's trying to keep people from engaging with it in the first place. But obviously, we know that decreases someone's self-esteem, which is actually a pathway to use more and makes a relapse a failure rather than part of the cycle of change and all the newer ways of thinking about it. So there has been, I think, a pendulum back and forth about how to see addiction. And again, the idea was alcoholism is not even in the DSM, but the idea was once an alcoholic, always an alcoholic, that you've been changed fundamentally and you can never touch substances again. And now ASAM and other organizations are saying this can be a chronic condition, but it's manageable. This is not something that has to define a person. It's really about what you do and recognize and how it's addressed, as opposed to, well, I'm a drug addict anyway, I might as well use it. Like, what's the point of fighting it? the newer perspective of this is something that's possible to treat and manage, and that people can have a fulfilling life. Also, knowing that it may rear back up.
Mhm. Yeah, it's very much that sense of choice, right?
Mhm.
That you have been an alcoholic, but moving forward, you choose to have some alcohol in your life or not. And even that sense of choice gives them better prognosis. Whereas, like before, if your doctor said, don't ever taste alcohol again, that lack of choice can be counter effective to long term sobriety. Because if you do have one drink, all hell breaks loose.
Right.
You might as well give up. So what they're doing now is to emphasize that every step of the way, there's a process of recognition, addressing, and making a decision about how you want to live your life.
And we know that from other fields too, that feeling trapped or disempowered is one of the most predictive factors for suicide and suicide attempts. And ACT, acceptance and commitment therapy, is all about enhancing cognitive flexibility and being less trapped and thinking about things from different perspectives. So even the idea of freedom and making a choice for yourself as opposed to having to XYZ can be very powerful.
Yeah, totally. So the DSM-5 has ways to identify addiction, which, as you said, Dr. Kelly, the word addiction does not exist in here in terms of the diagnostic labels. What we say is substance use disorder. So
Mhm.
we are looking at the pattern of use and calling that disordered use rather than abuse. We don't use substance abuse. It's just the pattern of use that was adaptive in the past that is now maladaptive and leading to harmful consequences.
That's a change in the DSM-5. It used to be abuse. Now it is use disorder. So as recently as 2013 is what we're talking about.
Right, in the last 10 years. Yeah.
Mhm.
So in the DSM, we're looking at specific criteria, the compulsive nature of the behavior. We're looking at the sense of lack of control, the persistence. So there's like a timeline, the negative emotional effect, and then this repetitive pattern of relapse and cravings. And then also, if you have withdrawals, that could be a sign as well. So there's a lot of different criteria, 11 of them to be precise. And you can see that this is for trainees. You don't have to ask every point in this criteria to get a feel for what's happening. Sometimes if you just let them talk, you can hit the marks, so you can get a sense of, okay, this is meeting that criteria.
Yeah, people are more than a checklist. That letting somebody tell their own story is so much more important than giving them a handout with the criteria and saying, check what applies to you. It's so much more nuanced than that. I'm really glad you said that.
Yeah, right. It's something for us to memorize, but not have to regurgitate. So now, knowing some of the definitions, it's important to highlight how multifaceted and complex addiction is. Addiction is not simply reduced to the action of brain chemicals and circuitry. It really has a very wide range of how it affects someone. And so, addiction has a biological, chemical, psychological, or emotional, social, political, and economic underpinnings. And we'll go into each of these categories, but it's something that I think people have a hard time wrapping their head around because, especially nowadays, you almost want one thing to blame. Oh, it's the dopamine. Oh,
Yeah.
it's the fact that weed is illegal in this state, right? Or it's because his mother abused alcohol. You just want to blame it on one thing, and it's never that simple.
Yeah, the multifactorial approach is so critical. I just have to say this, even though it sounds so snooty, is the word that comes to mind. But where I train, there is a slightly different way of formulating a case. We used, instead of the biopsychosocial formulation, we use something called the perspectives. And
Mhm.
that's really the idea of it, is that it's neither bio nor psycho nor social in isolation. It's the interaction of those things and being able to look at each one, but also understand how they inform each other. So we used to say that they were like lenses. So you can look at through the biological lens and see what those components are, in this case, use disorder. And then you can pivot and look at the psychological lens or their personality or temperament and their life story and all of those. And then through that, understand what levers you need to pull to help improve someone. It's almost never the case that it's just their biology, they just need a medication and they're good to go. Or it's just what they've been through, there's no biological component, it's simply an outcome of their experience, which is ridiculous to even say. That has had no impact on their neurological system. We just need to talk about it and they'll be perfectly fine. It's so much more complicated than that.
I may have to ask you about that on a separate, like, supervision. That's fascinating. The perspectives
Yeah,
approach.
the
Yeah.
perspectives of psychiatry. Yeah, that would be a lot of fun.
Yes. Yeah. So, starting with the biological aspect of addiction, we always get the question of, is this heritable? Can I pass this down to my child? Zooming out and looking at this, yes, there's like a 50-50 chance. But it also tells you there's a huge environmental component. Heritability is lowest for hallucinogens. It's about 0.4. Cannabis is about 0.4. Then for alcohol and tobacco, it's about 0.5. And it is highest for cocaine, which is 0.72. There's also the chemical aspect of addiction. This is really fascinating data, but there's a US national survey conducted in 2000, and it looked at the rate of dependence for first-time users of nicotine, alcohol, marijuana, cocaine. And they said that about 32% of first-time nicotine users develop long-term use, and 15% of alcohol, marijuana, and cocaine users develop long-term use. And then another survey about a decade later, another huge national epidemiologic survey in 2012 found that the lifetime cumulative probability estimates of nicotine users becoming dependent on nicotine at any point in their life, if they've used it once, becoming dependent on that substance at any point, is 67.5% for nicotine, 22.7% for alcohol, 20.9% for cocaine, and 8.9% for cannabis. First of all, it's interesting that the most so-called addictive substance really is nicotine, and it's legal everywhere if you're an adult. But you can see that there's a huge percentage that's not dependent on the substance itself. This illuminates the complexity of addiction. Like, there's got to be more to this story.
I think so
Yeah.
too. I think data and evidence is so important because sometimes when we're looking at trends, we find what we expect to find, and sometimes it's totally different. And I think this is probably very different from what most people would intuitively think, that cigarettes, tobacco, nicotine is so high and other things are so low, whereas most people would think the opposite because they associate addiction with potential harm or how much it alters a person, which is not really what addiction is about.
Yeah, there's the person's life experience. So that is the psychological aspect. There was a study that showed the 95% remission rate of opiate users among Vietnam War veterans once they return home and reintegrated into the society. As some of you might know, PTSD became a recognized condition, especially after the world wars. So the addiction did not rise from simply the chemistry of heroin or whatever they were using, but the needs of the veteran who used that drug in that moment. And then, of course, the ACE study is a very famous study on children and the physiological and medical consequences of early childhood adversity, including family violence, abuse, and neglect. All of these increase the risk of addiction by 2 to 10 times, depending on what kind of ACE risk you're looking at. So there's a huge psychological component. And then for me, this was like the harder thing to really wrap my head around is the societal, political, economic context in which we live. When you're learning about this in medical school or residency, there's a way in which you want to remove from that because you're looking at the disease and the chemistry of it, the mechanism of it, but then you cannot deny what's happening in the community that these people are living in. So obviously poverty, lack of access, and inequality, these things are huge risk factors. But also the way our country is going in terms of political discourse and economic incentives. So, the whole war on drugs, there's so much behind that, from the rate of incarceration to this idea that you have this enemy, which is the drug, but it doesn't take any accountability for what societal context does to the individual person. Cigarette companies, right? They sponsor a lot of political campaigns. And so there's an economic incentive to promote them. So, what can we tease apart between something very biologically, psychologically based, or in a bigger lexicon of society as a whole? You always have to bring them all together and be okay with the mess that it creates.
That's perfect. That is the perfect way to think about that, because it is. It is a mess, but it's like the Christmas lights when you pull them out and they're all just tangled up and everything is sort of stuck together. But that doesn't make it unentangleable. It just has to be the right approach to be able to pull apart what string is what, and what is environmental, and what is biological, and what is psychological, so that you can change those variables to give the person the best chance to succeed in their goals, which for a lot of people is moving past their use disorder.
Yeah. So, why is addiction so hard to stop? I think this is important for us to really examine, because we have this way of creating otherness with addiction. Like, they are them, that's a bad behavior, and I have nothing to do with that. And I think that is so problematic, because if you read anything about addiction, you can see how relatable it is. It's so relatable with substance or eating disorder or OCD symptoms, or we've talked about this before, but even overworking itself is a form of escapism and avoidance of something, right? The sense of a break from the pain of reality. And it allows you to not use your prefrontal cortex, which is so tiring and exhausting. We know as adults to have to organize our days and check off to-do lists. Like, it's so exhausting mentally. It also reduces cortisol. And cortisol is the stress hormone, and it raises your risk of infection, autoimmune disorders, and all kinds of diseases. It's not a friendly hormone. So if you can get a break from using your brain so actively and also reducing your stress hormone, why wouldn't you? Why wouldn't you do this?
And I
Um,
think we talk about how to do it without chemicals all the time. Mindfulness, yoga, distraction. We talk about all of these coping skills and these ways to regulate yourself. And so if there's a cheat code to that, if there's a way to just do that quickly without having to put that work into it, I mean, you'd be a fool not to lean into that.
right. And I think that's actually the really key point here, is that there's a difference between mindfulness, relaxing activities, and euphoria. The sense of overwhelming relief and dopamine hit. You've got the endorphins just surging. It's unrealistic. It's imbalanced. And that euphoric feeling is very deceptive, because you think you feel better, but it's really just an extreme that doesn't last. And you're brought back down to this net neutral. So then you're always comparing yourself to that euphoria, and you're thinking, that's how I want to live my life. Well, ordinary life is not that way.
Right.
I think also there's practical ways that these substances or addictive behaviors can be relieving. Like, it gives you a sense of confidence. If you have social anxiety, if you have performance anxiety, it can be just in the moment so effective. So then, of course, it tells the brain and your mind to continue to do this, because you have noticeable, tangible results from this. So all of these things can be positive to an extent, but over time, it becomes part of you. Even with my early example of that patient who lied to his family about going through detox, it's almost like he could not exist without this. And so that lie becomes just part of his story. Over time, there's no possible existence of that self without the addictive behavior or substance. And it becomes part of your identity at the cost of everything. It's not who you are, but part of who you are. that's why it becomes so hard to detach from, because it's filling a void that nothing has been able to fill. And so it's almost like pulling off an arm. Like you can't function without that piece of you.
And I think your instincts or your survival mechanisms themselves are taken over in a way. People who are going through detox, people who are separated from the substance to which they're addicted, look like they're starving to death, or like you've told them to hold their breath and sit in a corner. And the brain is a funny thing that it will motivate people in ways that are literally irresistible to get those things. A starving person will eat whatever's in front of them. And someone who is addicted to a substance, this is part of the definition, will continue to use it no matter what, if they have any possibility to do that. So it takes a lot of work to be able to make different choices in those moments when it would be easier to go back to using what your brain is telling you to do. It's really tough. But the experience, I think, from the patient side is so practical that sometimes it jumps over the why into the how.
Yeah. Addiction also has a very, very close tie to trauma, not just a huge catastrophic event, but slow, insidious, little t trauma of feeling like you don't belong, invalidated, isolated. So if you are feeling not worthy, you will turn to something to fill that void. So we really do want to bring it back to childhood, because these kinds of trauma make a lasting impact later on. So happy parent-child interactions release natural opiates and dopamine in the child's brain to build this consistent, secure attachment. We make natural opioids and dopamine in our brains. So this is a profound foundation for that security feeling at the chemical level.
That's an important concept that is sometimes glossed over. But the example I go back to is cocaine. There's no cocaine receptor in your brain. That cocaine itself works by activating the brain's natural reward system. The substance cocaine itself is not necessary for those feelings. That is your internal reward system being overly activated, dumping a bunch of dopamine, but the dopamine is there to begin with. So if we didn't have that to begin with, cocaine wouldn't do anything. And you can actually make like almost cocaine antibodies. You can make sort of a cocaine opposition chemical that prevents it from stimulating that system. So there's nothing magical about that substance. It's working with what is already there. And so I think it's important to know that evolutionarily, we are designed to have things that are rewarding in that way that start in childhood.
Yeah, it goes back to what we were saying about only 15% of first-time cocaine users will develop long-term use. And so it's not just about having that chemical there, but the reward system that exists there through development and how it responds to that cocaine. So they did studies on animals, which again, sad, but grateful for this information. When they studied rats separated from their parents early in life, they exhibited permanent disruption in the dopamine motivation system in the midbrain. Also, rat pups deprived of their mother's presence in the first week, even in the first week of life, were much more eager to take cocaine and alcohol. So, exactly what you're saying, Dr. Kelly, is the setup before exposure to the cocaine is what drives that behavior.
Yeah, it's a built-in system. I think it feels very natural in a way. The closeness and feeling good is mimicking something that is so evolutionarily natural that you don't really realize the insidious nature of that at the time. And so it can be very trapping.
Early life parental deprivation also leads to decreased production of oxytocin, which is one of our favorite hormones for us, is the building blocks of attachment and love and commitment. All of these things point us to how important that early life relationship and bonding is. So that actually brings us to a very, very important large scale study that was done in the early 2000s called the ACE study. And I think a lot of us in this field are fairly familiar with this. It really revolutionized and changed the rhetoric around mental health and physical health and how all of that is related. So, just to kind of give an overview, so the ACE study looked at 10 different categories of adverse events, and these included family violence, parental divorce, substance abuse in the family, death of a parent, and physical or sexual abuse. And so, if you had one of these, so if you had one ACE, the risk of early initiation of substance abuse increased by 2 to 4 times. So just one ACE and you double to quadruple your risk of substance abuse. And if you had 5 ACEs, the risk of substance abuse increased by 7 to 10 times. So you cannot ignore numbers like this.
Research doesn't typically show this. This is a huge effect. I think this surprised the researchers too.
Yes. That's the biggest thing is that we'll see like 20, 30% increase, but this is like triple, quadruple. And so obviously something is really huge here. I think a lot of people caught on how ACE impacts cardiovascular health and dementia, but because they looked at so many outcomes, the other side of it that was very evident was the risk of substance abuse. 2/3 of injection drug users meet criteria for early life trauma. So basically, if you're turning to IV drug use, there's some level of early life trauma that's happened in 60, 70% of people who use it. So I think the ACE study gave us a lot of language that people can easily understand to relate how trauma is so impactful. But also, one of the things that I'm not fully convinced of is that if you chalk it up to like one ACE or 2 ACEs or 3 ACEs, you still ignore what the actual story is. It did almost simplify too much, like the concept of trauma in my mind. But that might be because I'm just coming from a highly specialized area. And so for me, this is like an oversimplification of a highly complex idea, which is at the individual, biological, societal, political context. But I understand that it's a starting point.
Right. Yeah, I think it's one way to see it. And I do think the impact of the ACEs is impressive in not a good way. It is hugely impactful, but it's not the whole story. There's a lot of other factors, and you can have 0 ACEs and still fall into substance use, and you can have a ton of ACEs and still avoid substance use.
Yeah.
It's not perfectly correlated in that way, but I think it's a piece.
Yeah,
I think at the
exactly.
time it's a piece that was very helpful because this is the era of the war on drugs, and this is the area of it being painted as either a pure biological process of addiction or almost a personal choice, a moral failing, as opposed to a product of what you've experienced in the past. And so I think it introduced complexity into what people were otherwise trying to overly simplify.
Yeah, and that moral shortcoming, that kind of idea was so ingrained. If you are addicted to something, you have a choice, you can walk away from it. It really isn't that simple. That myth has been totally debunked. So, another concept that ACE doesn't capture as well is generational trauma. And I guess defining generational trauma is also difficult, but it's something that we may not be consciously aware of, but that we carry with us. And then we behave and act in a way that reflects what our parents, grandparents, ancestors have suffered from. And so we're talking about things like the disproportionately higher rate of substance abuse disorders and suicide in the Native American population in our country. They have the highest drug related deaths. And in a study that looked at numbers between 2013 to 2017, the alcohol induced deaths were highest among Native Americans with 93 per 100,000, followed by 12.9 per 100,000 for whites and 12.2 per 100,000 for Latino groups. Non-Hispanic indigenous people in the United States die by suicide at a higher rate than any other racial ethnic group, according to the CDC. The scale is like 10 times. You can't deny that. So generational trauma is passed down unconsciously, and it's a really important type of trauma that ACE didn't quite capture as well.
Yes, very true. It's one way of seeing potential exposures that hangs together, but it's far from all of the potential traumatic experiences.
Right. So, how is all of this trauma related to addiction? It goes back to the stress response system. If you're going through a lot of this trauma and your stress level is chronically elevated, the relief from that stress by using substance, the relief is that much higher. So, whatever is the stressor, you need the same level of reward and relief to alleviate it. From that standpoint, you can see how the more you're struggling, the more that substance or addictive behavior is addicting. If you are happy and content, you are not at risk for addiction. Even if you use cocaine, meth, whatever, acid, it's like a one time, oh, that was nice, that was interesting, and you move on with your life. But if you have this deep rooted void and unfulfillment and lack of purpose, that relief is so much more enticing. And so then you go back and back and back. And then it becomes truly a physical chemical dependence where if you stop, you have a seizure or the shakes. So then it turns into a full blown medical condition. But it really does start with this wound in the emotional space.
And we do know from research that the most addicting potential of substance is not necessarily the reward euphoria. So
Yeah.
these, oh my God, I'm so hungover. I was using meth all weekend and now I feel so depressed and I have no energy to get back up to the feeling of normal is actually much more addicting than using in the first place. And so there are always those stories of people who did cocaine once and that sort of unlocked something and they couldn't stop using, or did meth that one time and it was like their life opened up and that was it and they're addicted to it after that. But that's really the minority. It's usually the case that you fall back into doing something just to get back to normal without realizing that each time you do that, you're digging the hole deeper and deeper into addiction.
Right. That's such an important concept of it is a form of survival. You're aiming for normal because where you are is so intolerable. So it feels like the only solution.
I do feel like
Yeah.
that's not that this is what we're here to talk about, but I do feel like that's a fundamental error in how the medical system is devised in general, because typically our way of dealing with addiction in the emergency room and the way that insurance companies reimburse for addiction treatment programs is once you are through withdrawal, you're done. That is the goal, is to get through that. So in the ER, someone will come in with methamphetamine, not because of that by itself, but because of their behavioral dysregulation or their psychosis or whatever. We get them through that and then send them back out when in theory they're most primed to reuse because they want to feel normal. Or someone goes to detox and then their vital signs stabilize and insurance says, okay, you're done. It's time for you to go, when they're most primed to reuse. So it's a different topic,
Uh,
but there's a problem in how we treat this to begin with, I think.
yes, that is so true. That's the most sensitive time post hospitalization. We like buckle down and want to see patients like every week if possible. Maybe we need to have an episode on how we disagree with insurance companies, but that's for another day. But speaking of interventions and treatments, we have changed our approach to addiction in general. We stopped having this tough love approach and started embracing autonomy and decision making capacities, whatever they have, and meeting them in that moment. This approach is called motivational interviewing these days. That's a huge, huge part of the evidence based psychological interventions for addiction. Now, I think there's still some debate about how this more compassionate approach can be helpful or not helpful, depending on the severity. Because sometimes, if they are homeless and just in this chronic pattern, some level of structure and boundaries are helpful if they want it. And so, motivational interviewing, when I first learned about this, it just opened up a whole world for me because it is so counterintuitive to what you think might help people with addiction, because you're essentially doing this dance of letting go at the right time and trying to evoke them to change talk, is what they say in motivational interviewing. The more you say the positive things about making this change, the more you convince yourself. And so it's kind of CBT in a way. It's that sort of change your behavior before you change your mind, but also it's kind and humanistic and flexible.
I love motivational interviewing. It's one of my favorite techniques, and it works for so much more than just addictions. Any behavior change, motivational
Yeah.
interviewing can be so powerful. It's respectful, it honors the person's ability to choose and freedom to choose. It really pulls the internal motivation. It gets away from being controlling or feeling controlled. And lots of people who come from a background with trauma, there are so many control factors that it can feel artificial because they're so used to being stigmatized for it, or it has to be so hidden and so full of shame and guilt and regret. To have that sort of open, non-judgmental, we'll talk about it if you want to talk about it, it's a totally different approach. We do a lot of work with children, and I think sometimes if we're talking to children, it throws parents off because parents are saying, let's take addiction, get my kid to stop drinking. And you're talking to the child and say, can we talk about drinking? And they're like, what do you mean, can we talk about it? Of course we're going to talk about it. That's why we're here in the first place. So it can feel a little jarring, but it works. It works extremely well.
Yeah, and it works in a long-term way. I always emphasize that. I think in the short term, you feel like you're fixing something if they stop a behavior, right? Even if it doesn't last, you feel like you're doing something, but you might be doing more harm than good, because what you've taught that child is that in order to fix something, you need to listen to somebody else tell you what to do. And that's just not really a long-term way of building that self-confidence and self-trust, which is so crucial to preventing relapse. If you don't trust yourself to maintain sobriety, you're going to fall into it. And so it is really tricky. When someone is in that space of addiction, there is so much shame. And the shame is very quiet. It's unspoken. And, what people need in those moments, it's really love and kindness and just believing in being able to get through it. And so if you're not able to generate that within yourself as a caregiver, as a parent, then you have to do some internal work. And that's the hard part, because it's hard to make time for therapy, for reflection. We have like a million things in our schedules. But if you find yourself not able to find a warmth in your heart to support that person, then the only thing you can really control is yourself. And so it goes back to what is happening inside of you.
Absolutely true. And and to be clear, none of us are saints, right? It's not that we are immune to negative feelings and we always feel unconditional positive regard towards everyone we meet. And, part of it is being able to tolerate when a patient gets really pissed off at you. And all of that is in the room. But that is a recognized component of motivational interviewing, and that's a recognized component of addiction treatment and management to begin with, right? Even Alcoholics Anonymous has had Al-Anon associated with it to care for the caregivers. And the idea that this is really hard, and managing your self in working through someone with addiction can be a really important piece of the puzzle, because a little slip can be consequential for the other person. If they feel judged or if they feel put upon, we don't work in a system where we have that degree of control. Like, we're not on an inpatient unit, we're seeing outpatients, so they may just not come back. And that's where I don't think the quote unquote failure is someone using again. That's actually built into the cycle of change. I think the failure is if they don't come back. That's where it gets tough.
Yeah, that's really well said. We have to meet them where they're at, and for them to keep that motivation, at least to come back and show up in the office, is to be in it with them, be in the struggle with them, try to figure things out together, try some things. If it fails, okay, let's try another thing.
Yeah, I would much rather a patient come back and tell me why this isn't working and why they want
Mhm.
to use or why they did use or why they hate coming to see me than just not come back. Because then at least there's a dedication to the process as opposed to like giving up. And I think in psychoanalysis, sometimes we overanalyze things, but I think some things are correct. And sometimes resistance truly is resistance. And it can feel like I'm bored or I'm tired or my therapist doesn't understand me or whatever, but it can really be, I don't want to change. And this is an
Mhm.
excuse for me to not have to do that.
Yeah, actually, it reminds me of one patient I was working with who said that it was out of boredom. But if you dig into it, the boredom was rooted in, well, I'm not supposed to be bored because I'm supposed to be this grand person, this person that my parents would be proud of. That boredom is a sign of failure. You might not think that way immediately because if you say bored, you think of laziness or just being unmotivated, but that's not quite the case. The motivation is very much there, but it's this sense of I'm not good enough, I have failed, I'm not living up to my parents' standards, I have fallen from grace. He's calling boredom, but it's really the slow sense of worth.
It's a journey to be able to figure that out. And you have to be with someone with whom you feel safe in order to do that work. And that's a big piece of motivational interviewing is not judging the person and being open to them doing that exploration and doing it with them. So if they hit something that feels so vulnerable and you get to a place of, I really don't feel like I'm worth anything. And if I'm bored, then I'm lazy and stupid and I'm all the things that I fear the most about myself. That's hard to do in a room where you feel like you're being judged.
Yeah. Yeah. So that's more of the individual work that we do is slowing things down and really trying to understand, but also doing some behavior activation through CBT and relapse prevention. We have safety nets, like we don't have things that trigger us to want to use around us, no alcohol in the house, period, or we hang out with people who don't drink or smoke. So I think there are also very important behavioral things that when they're ready, when it's time, that will propel you towards your goals. So I'm imagining if you're listening to this podcast, you are most likely a caregiver, worried about their child or partner or family member. Maybe you're also struggling with this yourself. Either way, both sides need to hear this. How families, friends, partners, caregivers can approach that person who is suffering from addiction. And as caregivers and supporters, we want to provide this unconditional love and acceptance, but it doesn't mean that your boundaries can be crossed. So you first have to pause, step back, and say, what are you willing to accept and not accept? Not because of what it does to them, but what it does to you as a caregiver. Because if you're not well and you hold resentment, they will feel that. They will feel that judgment and resentment, even if you don't speak any of it. So make a choice within yourself about whether, first of all, you want to stay by their side or not, or have distance. And then, second, if you're staying, what are specific things that are okay and not okay for you?
And I think the idea of getting help yourself or seeing a therapist yourself or going to Al-Anon or finding a community around this, those are big decisions to make. And it can be hard to do just by yourself. That is something we often talk about and frequently recommend, frankly.
Yeah. It doesn't have to feel like a sacrifice. Certain things like dishonesty or unreliability, these things, if you put up a boundary, it helps them because it pulls them into the severity and the reality of what their addiction is doing to them and their family. And so not to guilt trip them. That's not the intention. The intention is to protect you so that you can be a whole person to help them. Another thing that is unintentional but commonly done is this sort of self-righteousness that might spring up because you're not doing the thing that's destroying the family. You're not gambling. And so there's an undertone of self-righteousness and judgment that they then can feel as well. So how do we recognize this and be conscious about this? And so the way that you handle this is to just express how these actions affect you, not to blame them, but to communicate, again, what you will live with and not live with. At the end of the day, you can really only do so much, and there's a limit, a certain level of letting go that needs to happen.
For providers too. Providers listening to this or treaters listening to this, that's extremely important. There's no faster path to burnout than overestimating your own control and sense of responsibility.
Yeah, the savior complex.
Yeah, it's real. It's real and detrimental, both of those things.
Yeah. So I do want to say that we're talking more in this kind of pathological diagnostic sense, but I think this topic exists at so many levels. I can just say that, even part of this work, right? I love it and I enjoy it, but I can feel that sometimes if I'm not feeling very well, I'll turn to more busy work just to fill my time so I don't have to think about things. And that's a form of escapism that has a potential risk for addiction. And so I'm not denying the ordinariness of this, that everyone has this. And it's not something we completely extract from our day-to-day lives, but it's something that we want to be aware of and have a way to cope with.
Absolutely true. And I sometimes think that the sense of non-normality that comes along with addiction is someone's own defense against it. Like, that could never happen to me. That is so abnormal. Oh, that only happens to people who are XYZ, right? As opposed to, this could happen to anyone for anything. And it's not just substances. There's video game addiction. There's caffeine addiction. There's the idea of procrastination through productivity is something that I've certainly fallen into myself. I'll organize email up, down, left, right, and center instead of just answering it. Yep, I certainly understand that. And so sometimes finding that core of we're all human, we're all going through it. This is something that everyone goes through to a greater or lesser extent. And there's a way out of this that is not motivated by shame. That shame is not an effective motivator for recovery.